So I'm Sarah Humphrey. I'm the Associate Clinical Director for Dementia, Frailty and Learning Disabilities for the Bradford Health and Care Partnership. I'm a GP with an extended interest in older people. And what I really want to talk about is a bit of, I suppose, some of the horizon scanning, some of what I think is some quite interesting stuff that's coming up, just to give you a bit of a new perspective on things. I'm not going to go into this in great detail because I can see from the people on the slide who joined the chat box that actually you know most of this. You know that dementia is an umbrella term for a clinical syndrome that involves memory, thinking, problem solving, language and perception. It affects about 1 in 14 people aged over 65, and that incidence goes up with age. And the number of people who are likely to diagnose with dementia is going to go by 2040 to about 1.5 million. If we think of dementia being that umbrella term, Alzheimer's, one of the types of dementia, accounts for about 60 to 70% of cases. Dementia as a group is the leading cause of death in the UK. People are often really surprised at that. And that's because most people over 80 die from dementia. The average survival rate time after diagnosis is about 4 years, though that is an average, remember. So some people will live a lot longer after diagnosis and some people will have a much shorter time to death. The cost of direct care to people with dementia in the UK is about 34 billion, rising to 94 billion by 2040 as those numbers increase. Most of that is NHS, social and residential care costs, but you have to remember a significant amount of money is borne by people living with dementia and their families. Mild cognitive impairment, again, is a bit of an umbrella term, and one type of mild cognitive impairment is of the Alzheimer's type. 50% of people with mild cognitive impairment will go on and develop Alzheimer's disease with time, but 50% won't. Okay, so that's an important one. And the reason why we talk about mild cognitive impairment when we will come on to disease-modifying medications, treatments. And they reckon about 1.6 million people in the UK have got mild cognitive impairment. I often talk about what care pathways, and I put this on because lots of people don't really understand what happens and how do we get to a diagnosis. So I put this on, and I want you to think about this when Sarah comes on to do her bit about what's happening in our memory assessment service. So at the moment, people with symptoms or their families come to the GP practice, what we'll call primary care, and there they'll have some screening tools, possibly. They may be triaged, and they may be watched, what we call watchful waiting. And then people with a possible memory issue or dementia are referred into what we call secondary care service, our memory services. And then they have a whole lot of tests and assessments, and they meet doctors and nurses and psychologists. They may have scans for subtyping, and then they'll come out with a diagnosis. Some of those people have dementia, some of them will have depression, some of them will have this mild cognitive impairment, and some of them will have no medical problem at all. And then that's how they access research and support. So that's what it looks like. These are the challenges. Lots and lots of people come into general practice either very early in their disease path with very rare or ill-defined symptoms. And we have barriers to access like language problems, long waits, and they get into the GP practice and they're seen for what we call widgets of 10 minutes of time. So the average 10-minute practice appointment is 10 minutes long. You can have multiple, but that's what you get, 10 minutes. And you might be seen multiple times, but 10 minutes is your bit of time. We have big workforce and capacity issues in primary care. We have screening tools that aren't always fit for purpose for certain members of our population. We've got poor awareness, training and education in general practice about what is dementia and what are memory problems and what causes it. And we have this thing called lack of continuity of care, so you don't see the same person twice. We also have the GP contract, which is telling us what to do. And that GP contract might not be prioritising dementia awareness and detection. This means that we have that green box as all those possible memory issues that could be a memory problem or dementia. Big box going in are then referred into memory services. Probably more people then can be coped with by the service we have, and that means that we have long waits at every stage. When you get into memory services, they have workforce and capacity problems as well. And then there's capacity problems for the tests that they're likely to do. So that means of all the people going in at the moment, yes, some people will come out with a diagnosis of dementia, depression or mild cognitive impairment, but some people will also, quite a significant number, will come out with no medical problem found. And all of this means that lots of people, and it takes a long time to get there, which delays access to support and to research. But anybody who knows me, innately positive person. And so there are some things we can do, and this is what we're going to talk about today. We're going to talk about biomarkers and how they might help in the future. We're going to talk about disease-modifying treatments. We're going to talk about prevention, and we're going to talk about the ApoE4 gene and just what potential these can cause. There are opportunities for all of these things to really mean that the right people get the right diagnosis as quickly as possible, and we reduce the number of people with no medical problem going through our system. That's in an ideal world. Okay, so let's first of all talk about blood biomarkers. And biomarkers. What are biomarkers? Well, biomarkers are things like blood tests results, like computer prediction models, like eye tests that give you a better idea whether that person could have dementia or not. So they're a bit of a screening test. They make it more likely that you have it or you don't. And then there are going to be potentially in the future what we call multimodal biomarkers, which means that they're going to put all of them together to give you a better idea whether you could have dementia or not. These biomarkers potentially could be used at the triage referral state. So all of those people coming out of primary care are referred into memory clinic. Memory services could think about using these biomarkers to give them a better idea of who should be seen by which bit of the service. So they might help in that triaging process. There are thoughts as well that they could be used by out in the community in the future by GP surgeries, especially the eye ones. So a bit like when you go to Specsavers to have your scan that tells you whether you could have diabetes, they could give you an idea of the fact that you might have a greater risk of dementia. You might need to do some prevention, all very future facing, but that's biomarkers. There's this thing called the 5 million blood biomarker challenge. And I thought I'd tell you about this because Bradford might be involved. 2 studies, the ADAPT study and the READOUT study, and basically looking at blood tests. And if you are interested in knowing more about them, I put a link so you could have a look at what's been set up for these 2 blood biomarker challenges. And this is going to be a significant step forward in knowing quite how they might help us. So that's biomarkers. That was just a quick canter. Okay, so the next thing we're going to talk about is the ApoE4. Now, lots of people ask me about this. So what is the ApoE4? So apolipoprotein is a protein that helps deliver fatty molecules like cholesterol to the cells in our brain. And in this case, these fatty molecules are good. I know we always say cholesterol's bad, but in this case, this is good. And these fatty molecules are really critical for cells to maintain their structure, what they are, obtain their energy and to talk to each other in our brain. And so we need these proteins, these lipoproteins, for our brain cells to work properly. And these are created by the ApoE gene. And a gene is something that gives instructions to a cell on how to make these proteins. What we know is if you have a version called the ApoE4 version of the gene, this is linked to an increased risk of developing Alzheimer's disease. Doesn't guarantee it, it gives you an increased risk. Like with all genes, you get one from your mum and one from your dad, so you have 2 copies. If you have 2 copies, one from your mum and one from your dad, one from each parent, that increases your risk further than just having one. So the way you need to think about it is if you have an ApoE4, it increases your risk and decreases the risk when you might develop Alzheimer's disease. So that's what it is. What we know is 2 people in every 100 have 2 copies, and 1 in 25 in every 100 have 1 copy. Now, why is it important? It's likely that we're going to use this ApoE4 test to know who should get disease-modifying treatments in the future, because it increases your likelihood of developing Alzheimer's disease. So it's probably going to be part of the license for using any disease-modifying treatment. So it's going to probably be part of the package of tests and diagnostic tools that people will use in the memory clinics to decide who gets disease-modifying treatments in the future. So let's now talk about disease-modifying treatments. These are the most exciting thing to happen in a long time for dementia. There are 28 medicines that have been identified that through what we call horizon scanning, looking forward, in development by 2030. So in the next sort of 5-6 years. 2 of them, lecanemab and donanemab, have already gone through the licensing process and have a UK license. But they are not for use on the NHS as described by NICE, and we'll go on to the reasons why in a moment. But the third one, which is got a different mode of action, is waiting for its license application to go ahead. And so we don't know about that one yet. But there are, as I said, 28 in the pipeline. What NICE do is decide whether the advantages of use and the cost outweigh the disadvantages, the side effects. And so at the moment it's felt that with these drugs, and I'll tell you why, that they're not for use on the NHS. But I honestly think, and so do most people in the industry, that it is a matter of time before we have a drug that we will start using. And that's a massive breakthrough. How do they work? Well, we have proteins in our brain, sticky proteins in our brain called amyloid plaques or tau tangles, which are thought to be a key part of how Alzheimer's develops. And these are toxic. They're bad for the brain. Lecanemab and donanemab are monoclonal antibodies which are given intravenously into the vein. And they bind, they stick to these proteins, and they trigger our immune response, our antibodies, to start clearing them out. Hydromethoxythianone is a tau inhibitor, and that's given by mouth, orally. What we know, our trials so far have demonstrated a moderate slowing of decline of our mental abilities rather than a full cure. And there is a relatively modest benefit, but there's important safety considerations. And these are brain swelling and brain bleeding, what we call ARIA. And the other thing to know about these is at the moment that they're pretty intensive pathways for patients. They have to have a lot of, they're intravenous, they're pretty, every few weeks, and they need lots of MRIs and lots of monitoring. So they're a really intensive pathway. I don't expect you to really, this is just to tell you, this slide, I know it's really busy, but this is just to show you how much is out there, all right? And that the drugs that are going to be potentially launched in the next 5 years cover most of the spectrum from mild cognitive impairment to mild to moderate Alzheimer's disease. And they're given in different ways, in different combinations, but that's just to show you how exciting this market is. But the challenges have meant that they haven't got a nice license. And the reason why is there are quite significant safety considerations. Remember I told you this, ARIA, brain swelling and brain bleeding. 2 of the medications that have gone through the NICE process are intravenous, and they need to be given every few weeks. That's really labour intensive. And they require lots of diagnostic investment. They either need PET CT scanning, of which only Leeds have it for the region, MRI capacity, genetic counselling for that ApoE4 test that we were talking about, and that's really intensive. And the feeling is we could spend all our resource on a few patients, and that would not help the majority of people with dementia to live well. And that's the reason that NICE have not given them approval. So it feels a bit like the last thing to talk about should be the first, but I just wanted to talk to you about prevention, because I think the other exciting thing that's come out this year is on prevention. What they reckon is that 40% of all cases of dementia are potentially modifiable if we eliminate risk factors. And if you want to have a look at this paper, I put the link on there. It came out in the Lancet in, I think, April, May this year. And it's a really brilliant, has a few infographics like this one I've put on the slide that really highlight what we can do and the potential. So I'll just quickly run through these, and then I'll let Sarah do her bit. So there are 14 potentially modifiable risk factors. So the first is in early life. The more you educate people, the less likely they are to develop dementia. In midlife, hearing loss is important. Having what we call a certain type of cholesterol, LDL cholesterol, being depressed, traumatic brain injury. So that's where you get all of this talk around contact sports involving the brain and things. Being physically inactive, all right, so again, a good reason to be active. Developing diabetes, smoking, blood pressure, obesity, and excessive alcohol. So there's loads of risk factors in midlife that if we eliminate those, that will, it's never too late. It's not all about early childhood. Midlife, getting people to think about their lifestyle. And then later on, what we know about risk factors are visual loss, air pollution, and social isolation in later life all increase our risk. I think that's exciting because it gives us something to talk about with people about, because people want to do something. So showing them this slide and how they can modify their life is really important. So that's me done. I'm going to move over to Sarah, and she's going to talk to you a bit now about memory assessment clinics. Over to you, Sarah.
Hi, thanks for that, Sarah. So yeah, I'm going to talk about what happens with a referral when it comes to the services and how people get a diagnosis. So I will just share my screen. And can everyone see that? Yeah, brilliant. Put it for the slideshow. So what I've done here is I've put some data on, because I think, you know, a lot of you do work in the service and you know that there's long waits, and being open and honest about the waits is one of the biggest things that I like to do. So what we've got there is the sectors broken down. So we have Airwharf, Bradford City, North Craven and South and West. And oh, sorry. What it's showing there is that the average waiting time for the first appointment is about 29.3 weeks, but you can see that there's a difference within the different areas, and that the average amount of time for those waiting for a diagnosis is around 40.5 weeks. So we're less than a year, but we're still round about that. And obviously, again, you can see the variables across the district. So that data is run from the 1st of July last year, so 2023, to June this year. So how are we going to sort some of them time lengths out? One of the things that the MAT service is commissioned for is assessment, diagnosis and treatment. And within an assessment, when somebody comes to the service, what you would be looking at is the history taking, doing the cognitive assessments. Now, depending on what cognitive assessments need to be used, most of the times we use the Adam Brooks ACE3. We also use a mocker. We have adapted ACEs with different languages and different cultures. We have an adapted mocker for visually impaired. We're just waiting for the hearing loss one to be agreed. We've also got the R-bands, which we use more in the young onset dementia. We have neuropsych assessments. We have the functional assessments, which we do further on, which look at OT and physio. We use something called the ACDM, which is where we give them a picture and ask them to place things on the picture to finish the picture. We obviously look at scans, so whether they need a CT scan, an MRI scan, a PET CT scan, a DAT scan. And then, like I've said, the neuropsychological assessments, just to see if we're not getting a full picture from the rest of them, what else do we need? This is all done at the minute in Bradford pre-diagnostically. So what we do is we have senior nurses and AHPs going to people's homes and completing the cognitive assessments, the functional assessments in their own home, as well as doing all the history taking. And then what we do is refer them for the scans. And then as soon as they get the scans, they come through to diagnosis, which is at clinic with one of the consultants or myself. And we look at giving a diagnosis. During this clinic time, we'll pull through the information that they've completed pre-diagnostically, go through some of the bits and pieces that they've been dealing with, and whether it's a treatable dementia or not. So in terms of the treatable dementias, it tends to be Alzheimer's or mixed, and for those we use the cholinesterase inhibitors. What we have to look for is side effects and whether there's any interactions or anything like that with any of the medications before we prescribe. It's a really difficult one because we have to make sure that the expectations from the patients, like Sarah's already said with the disease modifying medications, there isn't the cure, but this is to try and help slow it down and dampen it and maybe help with some of the confusion. So that at the minute is how we're doing the MAT service. We have been updating the MAT pathway and been working with the Royal College of Psychiatrists to have, and I know there was some in a meeting earlier, and this is the MAT pathway as to how we would like it to look in the future. And then this would be able to be given out to patients so that they can actually see that there's a flow. So the referrals received to our CMHTs, they're added to the waiting list, a letter's sent out and a leaflet. From that, we have the volunteer waiting well, which I'll talk about in a minute. We have the pre-diagnostic assessments, which we've just gone through on the assessments, and then they have a diagnostic assessment. If it's an MCI diagnosis, we put them back through the whole pre-diagnostic again in 12 months, just to make sure that it's definitely not changed into a dementia. We have the dementia diagnosis, whether it's treatable or non-treatable, and then if it's a no diagnosis, then it's discharged from the service. Or sometimes, if it's no diagnosis, it might be it needs to go to CMHT because they've unfortunately slipped through the net with a clinical depression or something else that needs to be sorted. We work very closely with the voluntary care service in the Bradford Dementia Hub. All our patients get referred to the Bradford Dementia Hub, and the dementia support workers go out and support them as soon as they've got a diagnosis. Our treatable dementias will have medication reviews in clinic, and the medication reviewed, which is something from the service user groups we were holding, was more important than having what we used to do was a nurse-led review. They found that a lot more beneficial. And then it's discharged from the MAT service and then into the community and the community services that are out there. One of the new things that I just touched on was the volunteer waiting well, which is where all the patients referred to the service will get the phone call from a volunteer, and the volunteer will be sat with our duty workers, so that clinical decision making is sat next to them to help if there's anything that needs more than just signposting or just how are you getting on. You are on the waiting list and hopefully you should be seen by this point. And then what we've also set up with James, Emma in the Admiral team is the Dementia Information Days, which have been running really, really successfully, where people with a diagnosis or even pre-diagnostic with friends, family and loved ones can come and have the discussions with all the different professionals in one room about what's going to happen and about their dementia. And that's had some really, really good success rates. And that's all I've got really about the MAT service. It's going through an awful lot of change. The MAT figures are getting better, but we need to fully implement it. We need to work more closely for young onset dementia with neurology, which I'm currently doing. I need to work more with the community services and looking at getting the cognitive stimulation therapy rolled out by Bradford Dementia Hubs, because this is something that the service users asked for. They said it would be better if it was delivered more in a community setting than secondary care. They'd be less likely to not go, because if it's secondary care, they might be a bit more frightened as to what's happening. So we've been listening to all of this and trying to pull it together to make it right. But obviously change doesn't come overnight, and I've got to win everybody over. So I'll keep going and keep plugging, and fingers crossed in 12 months' time, we'll have a lot better waiting lists than the data that I showed you at the very beginning.